Good day, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. It's my pleasure to welcome you today to our third quarter CAQH Core National Town Hall webinar. Before we begin our session, I'd like to mention a few logistical items. You can download a copy of today's presentation from the CAQH.org website after the end of the session. To do so, navigate to the Core pull-down menu at the top of the CAQH.org welcome screen and select the Core Education Events page. A link to the PDF version of the presentation can be found under the listing for today's webinar. On this slide, you can see a screenshot of the attendee GoToWebinar dashboard. You should see something that looks similar to this on the right side of your computer desktop. When joining today's session, it's possible you may have joined the audio portion of the webinar using your computer speakers by default. If possible, we would prefer that you join the webinar audio by telephone. To do this, please select the telephone audio button in the audio panel of your dashboard, and the dial-in information will be displayed. Make sure you enter your audio PIN, which is found under your dial-in information. We will save time at the end of today's program dedicated to responding to audience questions. You're encouraged to submit your questions at any time during this webinar by typing them into the questions panel on your dashboard. Today, we'll start off with a high-level CAQH Core update, followed by an update on the CAQH Core code combinations maintenance activities. After that, we'll share the latest information on the new Phase 4 CAQH Core operating rules, as well as the voluntary core certification program, including our progress towards developing a Phase 4 certification process. And we will save time at the end of the session for Q&A. And now, I'd like to introduce our first speaker, CAQH Core Managing Director, Gwen Lowe's. Gwen?
Good afternoon, everyone. Thank you, Jessica. We hope everyone is enjoying the last bit of the summer weather, so enjoy while we can. I think most of you are familiar with the mission and vision of CORE, and this is really going to be a critical piece to focus on as we're moving forward, because CORE started out as a voluntary effort, and then we have been doing work on mandated work, and we'll continue to do the mandates, but we'll go back to that voluntary piece about what does the industry want to do with or without any types of mandates. So we are here to drive the creation and adoption of the operating rules and to support standards and interoperability and align clinical and administrative activities and be the facilitator to have that movement evolve. And it is run by a multi-stakeholder board, and that board is really working on right now what is the future focus we'll talk about. If we see on the next slide, with regard to the mandate, as many of you know, CORE was designated as the operating rule authored by HHS for the ACA required mandates. There were 4 major things that related to operating rules in the ACA, and they were all in Section 1104. The first 2 related to eligibility, claim status, EFT, and ERA. Those operating rules and the underlying standards for them are out. They're mandated. Everyone should be following them. If you are on the line and you're an entity that's not getting the benefit of those rules, or you're not quite done implementing them, you want to get them done. They are required, and we want to get the benefits out. The third thing was certification, and it was just for health plans. And we understand from HHS they're going to issue a new regulation, and that has, there's no date for it yet. They're talking about potentially next year. So that requirement from HHS to get certified just for the health plans potentially next year, and that's the only information that we have from HHS. The fourth piece of the ACA had a number of other transactions, and those were all packaged into the Phase 4, which we're going to talk about today, except for the attachments, because there is no recognized national mandated standard or standards. And so CORE is going to be continuing to do some additional work on those. You're going to see that in the coming months, but not formally submit any type of operating rules to HHS until there's a mandated standard. So that is the overview. And if you think about what are operating rules, we're going to sit back here and where have we been and where are we going? So the operating rules, all the infrastructure is how does this information flow? And think of it as, you know, there are roads and then there's all the directions to follow the roads. So it's all the directions to follow the roads, how fast you move, when you stop, when there's an error, what kind of you know, manuals are needed, when do you acknowledge someone, when do you turn your signal on, and then there's actually the content. And I think one of the things we'll want to constantly remember as the standard setting bodies are working on new versions of the standards such as X12, the infrastructure rules can go with any version of a standard. Doesn't matter what the version of the standard is, the infrastructure still is applied. So you can just update that and put in the new version of the standard. The content rules support further use of the base standards, and they're updated as the standards are updated, but they just further use the standards. So all of this is really relevant as we think about what are potentially the new X12 standards, HL7's working on the attachment standards. You've got other transport standards or security standards. Those can all just be updated and all the rules still apply, and so they all work in unison. When we sit back, and this is not to go over in detail, when we sit back, where are we, you know, within a very short period of time for a complex industry, in a 4-year period, you now have national rules of the road for 7 of the major transactions that make up the whole financial system of payment in healthcare delivery service. So you've got these 7 transactions, and now you've got basic understanding of how fast the information flows, when it gets acknowledged, how you connect, when your systems are up, how fast you have to process data to get the receipt, all of those things, and that's quite an accomplishment for an industry that had no agreement on any of these things. You now, fast forward 4 years, they've got all this. I think that's pretty amazing over a short period of time. And we got to keep that in mind as we think about the future. So if we look at where we're going with phase 4, we, just as an update, phase 1, 2, and 3 are mandated. Phase 4, about 140 entities worked on those rules over a 2-year period, and there were hundreds of others that gave their input at various times. We updated NCVHS. And for those of you that aren't familiar, they're an advisory committee to the secretary during that process, and they hold hearings on the rules. That happened in February and March of this year, and they eventually wrote a letter to the secretary, and the core board responded to the letter. There were some folks that wanted to wait. They want to do voluntary adoption of the rules right now and kind of wait and see, maybe take out some of the rules, add certain rules, adjust. And the core board really feels that we built up a lot of momentum. There's extreme support for the rules and the momentum for the industry to take out all the costs and meet the mission and vision and all the statutory requirements of the ACA. We need to move forward. We shouldn't be waiting and seeing. So they were very clear with their letter, and you'll see just on the next slide, the core chair did write a memo out to the participants, and this is just a copy of the memo. And I wanted to highlight this here because as we moved from what was really a focus on a mandated agenda into a voluntary agenda, the board's always thinking, how does it keep its mandated responsibilities while it moves to its voluntary responsibilities? And they did focus as a board, and all the board members unanimously signed all these letters, and you've got providers, health plans, it's all executives. They feel very strongly that a voluntary adoption challenges the spirit, scope, and the purpose of the ACA, that they want to move forward. The rules meet the spirit and legislative requirements. all of the entities that worked on them made sure that the rules kept in the required scope and did not go outside of the scope. It met the statutory definitions. It also provided a much needed set of foundational requirements that are good business practice, and their initial steps. Across the board, there was always the assumption you're going to need to do more. These aren't the last and only step, but it gets us moving into a direction that has to happen. So moving forward with phase 4, you're going to see implementation support happen. You'll hear later there's a voluntary core certification test site launching. That's actually already been alpha tested, and now there's volunteers from the industry that are beta testing it. And you'll hear from case studies from early adopters, webinars, and there's FAQs up and implementation tools. And then with the commitment that phase 4 was a start, especially for the prior authorization, we're going to move to the next stage of building out more requirements there, while simultaneously the industry is working on those foundational things. So you're not waiting and seeing, you're focused on implementing and also developing more, so we can get to the bigger vision in a more quick manner. And part of that, you know, the considerations, of course, for potentially additional rules will take out a range of sources, including any of the testimony from NCVHS and the ideas there. And it is up to the Secretary of Health and Human Services if there is a regulation on phase 4, just like they're waiting on the certification or they're waiting on the attachments. There is no timeline right now from HHS on either the attachment, the certification, or phase 4. And that is up to, again, the leadership of HHS as to when those things will come out. So where is that all said, we want to continue to meet the strong commitment as the HHS designated author. There's rule maintenance, there's adoption of the current phases, and the work on the attachments when that comes out. That said, that's a lot of work. We still have focus on other things. So develop new rules like prior authorization, and then address things that relate to the emerging payment models. So moving forward with CORE, you're going to see a big focus on additional rules on prior auth, the continued HHS designated rules, and this emerging payment model. And I'm going to hand it over to Erin Richter, who's going to talk a little bit about the prior authorization.
Great, thanks, Gwen. As Gwen mentioned, we are going to be doing more work in the area of prior authorization. The 2015 CAQH Index Report, which I recommend anyone take a look at if you haven't already, it tracks industry adoption of the HIPAA transactions. That report found that the adoption rate for prior auth was around 10%. And given this low adoption rate, that's part of the reason phase 4 established basic expectations for infrastructure for this transaction, like response time, connectivity, et cetera. During rule development there, we heard from key stakeholders that more is needed, particularly for this transaction. So CAQH Core will be launching an effort to consider additional voluntary prior authorization operating rules. The board is committed to developing additional rules to promote standardization. The NCVHS has recommended additional prior authorization operating rules, and we heard a lot of different opportunities through some of the testimonies that have been provided over the last year and a half. And there's just a lot of opportunity, given that low adoption data, for improving industry ROI around this transaction. Slide 13 talks more about the timeline for some of this work. The core participants will really drive this initiative using our consensus-based transparent rule development process. Before launching rule development efforts and formal subgroups, we're going to conduct some outreach through a 2-part environmental scan to get a better understanding of some of the barriers to adoption and where operating rules might have the greatest impact. We've done an initial catalog of opportunities based on what research and what we've been hearing in the industry, looking at data content requirements, potentially formats for web portals, and or thinking about the role of what a prior authorization hub could do. So in the next month or so, we will be forming a prior authorization advisory group of 4 to 6 organizations that are core participants and are implementing and using that 278 transaction. Then later this fall, we'll be conducting an environmental scan, doing a core participant survey of all participants, and some more detailed interviews from implementers. And by the end of the year, we plan to launch a subgroup focused on rule development in this area. And certainly if this topic is of key interest to your organization, let us know. You can email us at core@caqh.org. We'd love to hear from you. I'll now turn it back to Glenn to talk more about the value-based work.
So as you all know, we're most of the transactions and payments, people estimate it's about 85%, 90% fee for service. And that is going to change. There are a number of value-based payment models being tested in the market, both by Medicare, but also by a whole host of commercial payers. And we're expecting to see the percentage of transactions that are under fee for service versus value-based, or you may call it alternative payment models, to change drastically over the coming years. So in anticipation of that, we need to figure out as an industry what kind of health IT for the administrative related transactions are going to need to exist to support those models. So rather than figuring it out after all the models are executed, let's get ahead of the game and figure it out beforehand about how we can help ease that process. So the board did decide to do a staged approach to identifying some opportunities, whether they be for core or for other entities. So first is a secondary review and some board dialogue. They identified 7 potential areas to interview entities on, and those interviews have been going on. And then we'll publish the outcomes. You're going to see 2 publications, and then determine if there's a core effort here or a way for core to support others in the industry with their efforts, because this is an important piece for administrative simplification and what is the appropriate role for core. With, you'll see in the next slide the 7 areas, and they go from everything from common data sets, and much data is needed to do value-based payments. You evaluate how the quality goes, or which providers are providing the actual services. There's standard terms and processes for when patients participate, or the provider identification, which locations are involved in which programs. Also infrastructure. Some of this data needs to flow really quickly if this is to happen, and access to claims, which can need high-level security. Infrastructure need, process rules, and then are we at a point where you maybe just need a library of strategies for risk stratification or best practices or measures? So those were some of the ideas that now the interviewees are having thoughts on, and you'll just see on the next slide, these are the type of interviewees that are being contacted. Many of them are not core participants, a whole range, different types of organizations, different value-based programs. Some of them are failed programs like ACOs, and different geographical diversity. And right now, from the 15 interviews that have happened, you're starting to see, no doubt, there's not a shared terminology around all this value-based programs. So if we don't talk in the same terms, it's very hard to see where the status is. So how do we start using the same terms? There's lots of fee-for-service, and truly going to value-based or full risk is not being done by the majority. There is more of a focus on bundled payments and pay for performance, although all the programs are a bit different, and there's a wide variation in the implementation and innovation. But the 7 areas are resonating well, especially the data sets and the definitions, and including around who's the provider. And so those are just very high-level findings. It's not meant to be in any detail. That will come later. And then for those at the CAQH core table, if you're participants, you will be involved in looking at the results and deciding what do you want to focus on, what are our priorities. And because it is in all of a voluntary manner to get ahead of the game and to have a cohesive way in which the industry is going to work together to exchange this data. I'll hand it back. Those are the current developments that CORE is working on right now, and we're excited about the future as we're moving forward.
Great. Thank you so much, Gwen. And this brings us to our first of two polling questions this webinar. We have a jam-packed agenda, so we're only going to do 2 questions. And so how this will work is I will read the question, and then on your screen you'll see a little window pop up for everyone to respond directly to the polling question. So this question asks, assuming the Phase 4 foundational infrastructure requirements are in place, what do you consider the greatest ROI opportunity for additional prior authorization operating rules? And so we'll just pause for a brief moment, and I will launch the poll. We'll pause for about 10-15 seconds for everyone on the webinar to answer this question, in which case we'll share the results. We'll take about 5 more seconds, and I might have maybe Gwen or Aaron or anyone else would like to respond to the results. And we have about 56% participating, 57%. Maybe we can get a few more percentage points. All right, I'm going to close the poll and share the results with everybody. And I see that 57% say that data content, and then 30% say format requirements, followed by 21% prior authorization hubs, and then 11% say other. Erin, what do you make of these results?
I think it's really interesting. Data content is certainly an area we've heard a lot about during the initial prior authorization rule development. I think there's a lot of different options within each of these 3 categories. So over the next few months, we'll be asking core participants to provide us with even more feedback on more detailed requirements within these higher level categories. So we look forward to hearing from you all.
Fantastic. All right, and with that, we will carry on, and we will continue with the program with the presentation on the CAQH Core Code Combination Maintenance Activities from Core Associate Director, Robert Bowman, and Core Project Manager, Amni Adekambi. Bob, go ahead, start us off.
Great, thanks, Drew. And just as Drew mentioned, we do want to provide an update on what we're doing now and how you guys can become involved. And what we are doing now is actually part of our rule maintenance process, and this includes the Core Code Combinations Maintenance Process. So what is this? CAQH Core is responsible for maintaining the core code combinations via a very specific maintenance process that our task group developed. Health plans have a way of reporting adjustments and denials using specific code sets, the claim adjustment reason codes, the remittance advice remark codes, and the group codes that are part of the TR3, part of the actual X12 standard. So these 3 different code sets are combined together and report out to the provider specific reasons for denials and adjustments for a claim. So it's really important for providers to have the appropriate code combination so they understand exactly what steps they need to make next in processing that remittance advice. So on the next slide, you'll see that why do we need a particular maintenance process for core code combinations? Well, initially, when prior to a rule being in the marketplace, there was a lot of confusion in the community about the use of the codes. And this was kind of just a natural evolution of the code combinations of different proprietary business scenarios that health plans used. Because every health plan can combine those 3 different codes any way they wanted to explain exactly how they, in that particular market, that geography, or that national plan, how they thought the codes should come together and explain that reason for the adjustment or the denial to the provider. Unfortunately for the providers, they were maybe billing 10, 15, 20 different health plans, and they're receiving 10, 20 different code combinations that are basically telling them the exact same thing. So the providers had a lot of process on their end to understand those code combinations, a lot of manual process and a lot of costly time to understand exactly what those denials meant, and then it was just specific for that one payer. Well, when you combine that with the potential for thousands of codes coming in, the providers really had lots of problems. Added to that, there's also the fact that the codes are updated 3 times per year. So the plans and providers were not using even the most current code sets or even the most current codes. They were even using deactivated codes. So there's lots of problems that were existing kind of by its organic nature in the industry for the code combinations. So the industry did determine that we, as an industry, needed to have operating rules to help maintain these codes and make sure that they are uniform and consistent. So on the next slide, you can see that with a consistent set and usage of the codes by all stakeholders within the industry, it helps really mitigate a lot of the problems that the providers have. They could reduce any sort of unnecessary manual provider follow-up. If we can reduce phone calls and clicks on a website, it helps reduce that problem for the providers. With a consistent set of codes, it also mitigates faulty electronic secondary billing or even rebilling, because the provider will have a more clear understanding of exactly what they have to do next in their business process to process that AR. Along those same lines, in processing that AR, it helps also mitigate inappropriate write-offs for billable charges, incorrect billing of copays and deductibles, hopefully helping your patients, and also reducing the time that it takes to post your AR, so reducing those delays. The effort for the code maintenance that we've seen over the last 3 years is less staff time spent on phone calls and websites, less clicks, for much greater processing of those remittance and the EFTs to automate that process. And if we can even get that needle to uptick just a little bit, the savings are astronomical for providers. It also increased the ability to conduct targeted follow-up with health plans and our patients, because now, again, if every health plan that you are billing reports the exact same way that you're missing a piece of data from the member or from the member's health record, you know exactly what to do next and how to resolve that issue and rebill that claim and ensure that the payment is processed more expeditiously. Again, more accurate and efficient payments of claims is what we're really striving for. But again, there's always more work to be done, and particularly in this area and arena. And I'm going to hand the call over to Ami now to walk through what we're doing next.
Great, thanks, Bob. So as Bob referenced, the core uniform use of CAQH and marks rule establishes a minimum set of 4 core-defined business scenarios with an applicable maximum set of associated core-required CAR, QARC, and group code combinations. These core-defined business scenarios were identified by the core participants as they target 80% of the industry's usage problems with the claimed and out code. The business scenarios and associated code combinations are maintained by the core code combinations maintenance process to which Bob refers. This process ensures ongoing compliance with the published code list and addresses industry business needs. 2 types of review and adjustment are applied to the core code combinations via this process. First, compliance-based reviews occur 3 times per year and only consider changes to the published code list applied by the code committees since the last update of the core code combinations. Compliance-based reviews are triggered when the current published CARC and MARC lists are updated, which occurs in March, July, and November of each year. Additionally, market-based reviews occur once a year and consider industry submissions for improvements to the core code combinations to reflect industry usage and address evolving industry business needs. Market-based reviews occur concurrently with one of the compliance-based reviews, so essentially we have 3 review cycles each year. The core code combinations task group is responsible for the ongoing maintenance of the core code combinations via the maintenance process. The group is composed of over 40 participating organizations, which represent a wide variety of stakeholders, and is led by 4 multi-stakeholder co-chairs, which are listed on the screen. The co-chairs are Shannon Weber from UW Medicine, Lynn Franco from United Health Group, Heather Morgan from Aetna, and Erica Zendel from Relay Health. As we've outlined, the task group's maintenance efforts are year-round. There is always plenty of opportunity to get involved and contribute to the task group's work. Currently, the task group is completing a compliance-based review in response to the updated CARC and MARC lists that were published on July 1st. The updated version of the core code combinations, including the task group approved compliance-based adjustments, will be published on October 3rd. Prior to this work, the task group completed a concurrent compliance-based, or CBR, and market-based review, or MBR. The CBR focused on adjustments in response to the updated lists that were published on March 1st, and the MBR focused on potential adjustments that were received via the 2015 Industry Market-Based Review Survey. The task group approved adjustments in response to this review cycle were included in the core code combinations that were published on June 10th. Slide 25 provides the timeline and process that was used to complete the 2015 Market-Based Adjustments Industry Survey. As you can see, the 2015 Industry Survey opened on December 10th, 2015, and closed on February 10th, 2016, giving the industry 60 days to submit potential adjustments. During this time, any stakeholder implementer, both core and non-core participating, could submit a request for an adjustment to the core code combinations via a standard online form. The 2015 market-based review was scoped to adjustments to the code combinations in the existing core-defined business scenario. As such, the online form allowed respondents to request additions, removal, or relocation adjustments to the code combinations in the existing 4 business scenarios. To ensure that the MBR submissions were well thought out, the online form required submitters to confirm that the requested adjustment met the core code combinations evaluation criteria, to provide a strong business case for the adjustment, and optionally, to include a summary of real-world usage data to support the business case for the adjustment. From March through May of this year, the task group reviewed the MBR submissions received and approved a set of adjustments which were published in the July 2016 core code combinations. The July 2016 code combinations also included compliance-based adjustments in response to the March 2016 compliance-based review. The table on slide 26 provides an overview by core-defined business scenario of the adjustments included in the June 2016 core code combination. Through extensive polling and task group discussion to reach consensus, the task group agreed to a set of compliance-based and market-based adjustments, including the addition of 119 new code combinations and the removal of 12 existing code combinations. At the bottom of slide 26, 2 examples are provided of the approved compliance-based and market-based adjustments and their anticipated industry impact. First, the task group approved the addition of new RARCs N765 and N766 to CARC 96 as a compliance-based adjustment in response to the addition of the RARCs to the March code list. The addition of RARCs N765 and N766 expands the code combinations to convey claim denials due to non-coverage of prior payer copayment or co-insurance. The task group also approved the removal of RARC MA88 from CARC 250 as a market-based adjustment. This RARC removal addresses inconsistent messaging between the CARC and the RARC to ensure better provider understanding of the remediation needed to correct the claim. With that, I will now hand the call back to Bob Baldwin, Core Associate Director, and introduce again Erin Weber, Core Associate Director, to talk about the upcoming Phase 4 implementation.
Great, thanks, Omni. And what Erin and I would like to do in this next section is really to provide you a scope of the operating rules for Phase 4 and why and how to implement them. And really what's going to be key here is the why. But basically, as Gwen alluded to, there are the 4 transactions in Phase 4 for the prior authorization, claim, enrollment, disenrollment, and the premium payment transaction. And these 4 transactions are all part of the Phase 4, and there's very specific infrastructure requirements for each. Now, many of these infrastructure requirements are identical to the previous phase infrastructure rules that we have in Phase 1, 2, and 3 for the eligibility, claim status, and the 835, the ERA transaction. So these align almost exactly with those exact same infrastructure requirements. For example, your processing mode, batch or real time, acknowledgments are required for the transactions if you offer them in batch or real time, as well as the safe harbor connectivity and security, system availability, companion guide. There are some specific requirements for some of these transactions, as you can see denoted in the table, but it's exactly for, or specifically for, that particular transaction and how best to conduct the transaction. Again, all of these rules were approved by vast majorities through the development process over the last 18 months or so, prior to them becoming finalized last year. So there's lots of all of the detailed requirements, as well as some of the supporting materials that we have, as Aaron will let you know in just a moment, on how to implement those. But what is key, again, is to understand why we need to implement those. And some of that reasoning is found on the next slide. So on the next slide, you'll see that by voluntarily implementing the Phase 4 rules now, your organization really gets a jump on the marketplace. You kind of establish your leadership in the industry as an early adopter, and we'll hear some quotes from some of those early adopters because they're already going through and they're being our beta testers. You can determine your own timeline. You can start now, or you can start the budgeting process or request for that now and move forward much more quickly than the rest of the industry. You can demonstrate your commitment to admin simp. Again, with some of the materials that you'll be seeing soon, you'll understand that this really does lead to greater efficiencies within your organization and not having to support many types of connectivity protocols that are in the marketplace today, causing more confusion. You can build on the work that you've already done in the previous phases. Again, you've already implemented these types of technologies, these processes for some of the transactions. Now you have the opportunity to do that for all of the transactions that your providers are submitting to you. So it'd be very important to kind of economies of scale for your systems. On the next slide, going into some of the details around some of the cost reductions and increased efficiencies. Again, response times and acknowledgments are part of the requirements, so providers will know, as well as clearinghouses will know, that nothing falls into a black hole. There's less time spent verifying any information over the phone because it's all through an automated EDI system, so it allows the systems machine to machine to communicate with each other and provide the updates and statuses appropriately. Providers can learn and know exactly if a claim submission was successful and if it's moved into the adjudication system by claim. So not necessarily just by a batch, but they can actually identify claim by claim if the system and has accepted that claim for adjudication. No longer waiting ad infinitum until maybe you get something on the remit about that claim 30 days later. Providers can immediately learn also if the prior authorization request has been received. The safe harbor ensures that providers can connect online for all of their transactions using the preferred connectivity method. Providers can also improve COB through more timely eligibility information from the health plan. You get to understand exactly what those COB requirements are because they're required to be published in a companion guide as well. So providers get more information that they need to ensure that they can bill more accurately and more timely. Health plans can build on investments they've already made. Again, that economy of scale that's really important. So you've already built this technology and these systems for your eligibility and claim status and for the EFT. Now you can extend that to your claims and to the prior authorization transaction as well. And with that, I believe we'll hand the call over to Aaron to move into how stakeholders can implement the transactions.
Great, thanks, Bob. We have a number of tools available to assist with your implementation. The first I want to highlight is the analysis and planning guide, and we have this for all phases of the core operating rules, but specifically to this presentation for phase 4. There are 3 key tools within the analysis and planning guide that I want to highlight. On slide 32, there is the stakeholder and business type evaluation to help think about what aspects of your business or outsourced functions are impacted by the draft rules. Then we move into the system inventory and impact assessment worksheet, which helps you identify and inventory your impacted systems and products. And finally, on slide 34, the gap analysis. And this is where we have a detailed list of every single requirement within each operating rule, so you can assess what level of remediation needs to take place for you to become conformant with the rules. In addition to these tools, we have more than 100 FAQs available on phase 4 alone. I think we have more than 700 FAQs available across the board. So I definitely encourage you to go there as your first point of contact for any questions you might have. With that, I'll turn it back to Drew for another polling question.
Great. Thank you so much, Erin. And this brings us to our last polling question of the webinar. And just like last time, I'll read the question and then open it up for everyone to respond. This question asks, which stage or stages of implementing the Phase 4 CAQH Core operating rules are you voluntarily planning to complete in 2016? And there's a full spectrum of options here, so please check all that apply. And I will launch the poll, and we will pause briefly for everyone to respond. We'll take about 10 more seconds, so please go ahead and select right there on your screen. We'll take about 5 more seconds, and then I'll share the results. All right, I'm going to close the poll. We have about 57% answered, and I will share the results. The largest percentage, 47%, indicate that they're not planning on starting to voluntarily implement this year, followed by 38% starting internal education and awareness, so we're happy that you're on this webinar. 30% indicate analysis and planning or systems design, and then 15%, about 13% equal about systems implementation or integration and testing, as well as deployment and maintenance.
So Drew, we've got about, what is it, 68% that are kind of in the implement. Like if you add up the 38, 30, 15, it's like 60% that are kind of 68% kind of moving ahead.
Yeah, have started a few steps down the path at least, certainly.
Yeah, at different stages.
Correct, yeah.
Okay, great, thanks.
Bob or Erin, any thoughts? Or we can just move along. We've got a packed agenda here. So I'll hide this and we'll carry on. So next presentation, this will be about voluntary core certification by our core senior manager, Matthew Albright. Matthew, go ahead.
Thank you, Drew, and welcome all. Thank you for joining us all today. I know we probably have some core certification experts out there, but just to remind you what core certification is. Core certification is really the gold standard of what a certification program should look like. The main reason being that it is a certification program designed by the healthcare industry for the healthcare industry. The core certification program is unique because it has a balance of powers forming a kind of three-legged stool. First, the requirements for testing, that is the testing that all entities must meet in order to be considered conformant with the operating rules, are agreed upon by the 140 CAQH core participating organizations, which of course include all sectors of the healthcare industry, but most specifically the organizations which actually conduct the transactions. Second, a third-party testing vendor, otherwise not affiliated with CAQH core, actually does the testing. And lastly, the third leg of the stool, CAQH core administers the program and reviews the testing and applications according to robust processes and policies, and ultimately awards the seal. Here's a slide that shows the types of stakeholders that can be certified. Many of you probably rely on business associates to help you conduct these transactions. If those business associates are helping you, you can probably find them categorized as a group on this page, and they can and should be core certified. Here's some examples of entities that have become core certified. Core certifications, now at nearly 300, have nearly doubled in the past 2 years. So congratulations to all these certified entities.
And Matthew, just to emphasize, anyone that's core certified, obviously none of the mandated operating rules require acknowledgement, but every phase of the rules include acknowledgement. So these entities are going above and beyond what's actually required.
Good, and I think that's true, and I think that kind of resonates a theme that's been throughout this webinar, that you know, there's legislation that's been done, there's legislation that we're expecting, but following the core operating rules puts us above and beyond any legislation mandated or any that's expected.
Yeah.
So that's a good point. This slide is a good cheat sheet if you need to provide your leadership or, say, your compliance officer with reasons why core certification may be beneficial for your organization. This slide also demonstrates what you should expect from your various vendors and clearinghouses as a matter of course. If you look at the third row for the first two columns, it says, show that you are maximizing the efficiencies afforded by the operating rules and underlying standards. Maximizing the efficiencies, certainly we should expect that from our vendors and clearinghouses. Next slide, please. We've had quite an uptick in the number of state Medicaids, county-level Medicaid, such as Medi-Cal plans in California, and of course, commercial Medicaid managed care plans that have become core certified. And as you can see, between all these Medicaid plans, the majority of the country has Medicaid offered by core certified plans. As has been pointed out, Phase 4 operating rules are completed and being implemented by industry, and this fall, voluntary core certification will be offered for Phase 4 rules. Again, the Phase 4 certification applies to health plans, vendor solutions and products, clearinghouses, and providers. And we noticed that about 30% of you are in the planning stages. For some of that are already. So make core certification a part of those final planning stages, a part of your project plan when you actually go out and test to make sure that you're meeting all of the operating rules. And Gwen talked a bit about the current status of Phase 4 operating rules vis-a-vis the federal mandate, and it echoes things said by Bob in this webinar. To that end, I think the quote from this early implementer from Humana sums up why organizations should think about implementing and getting certified in Phase 4 rules. And to paraphrase, you know, as an industry, we need to get out there, make things happen, and not wait for regulations to tell us to do it. Back to you, Joe.
Great. Thank you so much, Matthew. And the last section that I'd like to speak very briefly on is education and outreach and some of the new education sessions, as well as some online tools and resources that we are working to offer you. So this just is an outline, and you might have seen these listed on the scrolling marquee slides before the start of the webinar, is a list of the education sessions that Jessica and I have been working on over the summer to schedule and have ready for you starting now and on into this fall. And so we just encourage you to go to our website under the core events website section there to register. Also stay tuned to your inbox. We'll be sending out promotions highlighting when more information about these sessions is available. So check out our website. Another thing I'd like to point out on our website, I have been busy working to put together some interactive e-learning modules as well as a Medicaid dashboard. And perhaps you've seen this already up there if you've been poking around our website, but if not, I'd like to steer your attention towards the e-learning resources section. It's a new section on our website, and there are two options available, both of them having to do with core certification. But the first one outlines the 4 components of voluntary core certification, and the second one is an interactive map to show you around the country, which types of Medicaid organizations have achieved voluntary core certification. And we hope that you find them useful. This is something you'll see a lot more of us providing you. And over the next couple of webinars, we're going to be asking some feedback based on your experience using them, what you like, what your preferences are, just so we can help hone and you know, make sure that they're what our audience is asking for. And so now, the remainder of the hour we have here will be turning over to audience Q&A, and that will be led by Jessica. And Jessica, why don't you kick us off here?
Thanks so much, Drew. And before we get some of these questions up on the screen so we can address them, a lot of questions came in as folks were registering, and there were questions, kind of basic questions on certification and also whether, what your status is, are you core certified, et cetera. And I think we've covered some of those issues and questions during this webinar, but if you don't feel that's the case, please go to our website and you'll find that information about whether your organization is certified, what the basic steps are to get certified, since we're running a little bit pressed for time. So the first question that we are going to take is regarding acknowledgement. So the issue is, when we are, whether CMS adopted acknowledgments in any of their recommended operating rules.
Yeah, and this is when I'll answer that. All the operating rules since CORE started have acknowledgments in them. And the operating rules that are mandated, which is 1, 2, and 3, the federal government encouraged voluntary adoption, but did not mandate the acknowledgement. I think one of the other questions, too, that might be good to talk about, Jessica, maybe Erin, you could handle this. With the options for prior auth, data content, format, hubs, what's some general definition of those 3 categories, and then how will the group define it more?
Sure, and Bob, feel free to chime in too. So from data content, operating rules are probably the most self-explanatory in this area, and those would be rules that define the data within the standard transaction. So those are information that would be helpful to be carried over in the transaction that's not currently there. So that's one component that we'll be looking at. The next is standard formats, and that's really thinking about, we know the industry is using a lot of web portals. Are there ways in which we could create the same look and feel so that providers are not working with different systems across the industry? For those that are familiar with the enrollment data rules, this was kind of a similar approach where the enrollment forms for EFT and ERA now look the same across the industry. So is there a similar opportunity there for prior authorization? And finally, a prior authorization hub. Is there a way to centralize how the industry is doing prior authorization? Again, these are very high-level concepts that we will be drilling down on in the coming months. So research is underway. We'll be doing some core participant surveying. So we really want to hear from you all as to where the opportunities are and if we've missed opportunities. So certainly reach out to us at core@caqh.org on that topic.
And if it was data content related, it would obviously support the X12 version, whatever version was appropriate.
That's correct. All operating rules cannot conflict or repeat what is already in the standard. So that would be a pillar we would follow.
Thank you so much, Erin. So Gwen, I think this next question is for you. Can you review what NCVHS specifically recommended for the Phase 4 operating room?
Yes, absolutely. So NCVHS strongly recommended voluntary support and no mandate at this time. And we actually, on one of the slides, there's a link to the NCVHS letter. So you want to go in, you want to read the NCVHS letter, and then there's also a link to the CORE board. They wrote 2 letters to NCVHS. If you think about NCVHS as saying there's some more work to be done, you could add things, you can remove things. And I think for the entities that participated in the process, it's that Goldilocks, where's the right place? And so the participants want to move ahead. So we figure out as an industry where to go next, both with regard to Phase 4, with regard to any attachment standard or any regulation on certification. Of course, CORE will continue to support its role as an operating rule author and work with NCBHS and HHS while simultaneously working to drive industry adoption, because CORE started out as a voluntary effort because the industry wants to move ahead with a national set of rules.
Thank you so much, Gwen.
And I do encourage people to go onto those links. I don't know, Drew, what page those links are on, so people can read the letters themselves.
And there are hyperlinks throughout that one slide that kind of goes chronologically. So
yeah,
we're being transparent. You can find that information if you click on those hyperlinks. Before the next question, I want to clarify one thing, because we're going really fast here trying to cram a lot of information in a short period of time. But our two polling questions were a check all that apply questions. So while 47% might have picked one thing and 64% might have picked another, those numbers don't have to add up to 100. It's just that people are choosing multiple answers. The next question is, I think, for Matthew. And the question is, are dental health plans, do they need to be following the operating rules?
So the short answer is yes. When you think about whether you're a health plan that is required to follow these rules, just think in terms of the HIPAA privacy and security rules. If the HIPAA privacy and security rules apply to you as a health plan, then the operating rules and the standards probably apply to you as well, even if you're standalone dental. And so I can say with certainty that the mandated operating rules that have been mandated so far do apply to dental health plans. It does get a little interesting when we talk about things that haven't been mandated but are in the Affordable Care Act, like audits and certification of compliance. But for those that are already mandated, dental health plans are in.
Thank you so much, Matthew. So the next question, and I'm not sure who this one is for, but the question is, so this is from a hospitalist group in North Carolina. Do we need to be aware of the CAQH core operating rules?
And Jessica, I'll answer that. So if you're in North Carolina and you're a hospitalist group, I'm assuming you're a provider group and you're seeing patients and you've got more than one provider in your group, you're seeing patients, you potentially have more than one health plan at a minimum. You probably have the regional plan and Medicare, probably some Medicaid patients as well, and maybe some other commercially insured. You should be aware of CAQH core, because if you want your payments to arrive more quickly, you want your remittance advice to match up with your payments, you want the claim denial codes that are really relevant to your particular specialty and your services to work better. If you also you want the enrollment and the premium payments, you don't have any patients walking in the door who actually don't have coverage getting services, and then you have challenges getting paid. Also, your eligibility at real time, when you have the patient at the time of service, you can get 20 seconds. If you want to check on your claims in 20 seconds or less, you should care. And you should be reaching out to your health plans that, are they participating in core? You should talk to your vendors that are the services that you're buying from your vendor systems to do all the administrative transactions following the rules. You can easily ask them to get core certified. So a very long response to that question is, yes, they should care, because there's a lot of benefits as a provider group that they can get.
Thank you, Gwen. And with that, for those of you that we either didn't get to your question or you want to know more, you know how to reach us. In the next slide, you'll see that there's our website, there's our email box, so feel free to contact us with your questions, and hopefully we have tools up there that can help you in your operating rule journey. I want to thank you for joining us. A recording of the session will be available and sent to you in the next 24 hours. And with that, enjoy the rest of your afternoon. Thank you.